It's my pleasure to be here this morning, and good morning, not only to be here among such an esteemed group, but to talk to you about a subject that is truly important. And as Margot said, it's not the sexiest topic. We're talking about arthritis, but the truth is, it is going to affect you in your lifetime. It's either going to affect you or someone in your family. At some point, this is going to impact what you want to do with your life. It's going to impact your lifestyle. And we're all going to deal with it. I'm going to talk to you today about multimodal therapy in the treatment of arthritis. And speaking of our family members, my mom makes the most amazing potato soup, okay? It is phenomenal. And when I asked my mom, can you teach my wife Karen, how to do this so she can make it? And what you probably all have oh, you just put a little of this and a little of that and a little of this, and there's really no absolute recipe. It's just the way she does it. The care of osteoarthritis is kind of like making soup. We take a little of this and a little of that and a little of this, and sometimes the recipe, the soup turns out different every single time. But it's right for you. It's the best for you. And I have patients in the practice that will ask me not to add this ingredient or that ingredient to their soup. And I'll say, why not? And they'll say, I heard it's bad. Oh, that's bad. Oh, my uncle took that and his toenails turned purple. Or something happened and, some bad thing happened. There are studies that show not a lot of us are aware of the treatment options for osteoarthritis. And what I'd like to go through with you are facts and fallacies about what's out there for some of the common treatments, what people perceive, what we perceive to be true, and what the latest research and medical science has shown us to be true, because what would be important to us as the physicians who speak is if you can take home a tidbit today and share it with a friend, a family member, and help their life, because that's how passionate we are about helping to manage osteoarthritis. The first is glucosamine. Glucosamine and chondroitin, you've probably all heard of it. My patients call it guacamole and croutons because they can't remember what it is. But we've heard of glucosamine, and I remember the promise of glucosamine. This is going to be the greatest thing. It's a natural treatment. It may even slow down the disease process. Glucosamine was really something. So the fallacies out there, well, it works, it doesn't work. There's a lot of misunderstandings. There's a fallacy that it rebuilds cartilage, that it restores your knee. I want you to understand that that's not necessarily true. Or because it's glucose, I have diabetics that won't take it. No, it's glucose. I can't take that. Because it's called glucosamine, it does not affect your blood sugar. It has no problems with your blood sugar. So the facts are, it's very safe. The GATE trial, sponsored by the NIH, is one of the only large-scale trials to really have good information. As Dan referenced, we have to have placebo-controlled trials. We have to go up against something. And one of the big trials that went up against placebo, I hate to say it, but it took the wind out of a lot of our sails. Glucosamine didn't do so hot. It did kind of as good as placebo, not as good as an active treatment in that study. It was Celebrex. But there was a group of people that it helped. There was a subset of people that it helped. So when patients ask about glucosamine, I'll say, go ahead and try it. In the risk-benefit ratio, it's not going to harm you. It's not going to hurt you. Cost you a couple of bucks per month. It's not going to cause any problem. Give it 6 weeks. See if it helps you. The next is good old acetaminophen. Tylenol took a pretty big hit last year in the media because Tylenol, unfortunately, had a bad bed partner because it's part of the medicine Vicodin. And there was a concern about Vicodin use and then what was going on with Tylenol. And then there was a lot of, again, misunderstanding. And the fallacies about Tylenol is interesting. Again, it works. It doesn't work. Oh, that stuff is candy. Oh, that stuff is, now we think it's toxic. The truth about Tylenol, and the problem is, if it is a medication, and if you take too much of it, it can be a problem. You know how men are. If 2's good, 8's better, right? That's what was going on with Tylenol. We were taking too much pain medicine, and people were getting too much Tylenol, and over an amount of 4 grams is bad for your liver. Can be very bad for your liver. It can cause liver failure. So the facts are, doses up to 4 grams may be initiated before the use of other medications. And for those who don't believe it, give it a try. It's the kind of thing you throw it in your golf bag or your purse or wherever you're going, and you take your Tylenol, and it can be very helpful during the day, but a lot of folks who think it doesn't work skip it, and a lot of folks who think it's dangerous don't understand it, It's safe and it's helpful at the right dose. NSAIDs are anti-inflammatories, non-steroidal anti-inflammatory drugs. Those are the drugs you know as naproxen, Lodine, Relafin, Dapro, a lot of the medications that we're on every day. Several years ago, I think we remember what happened with NSAIDs. They also had a little bit of a problem. Fallacies, they are the treatment of choice in OA. They're a reflex for physicians. If something hurts, you get a prescription for an anti-inflammatory. We've been doing it for years. We're finally taking a look at that and wondering if that's really the right thing to do. So NSAIDs may not be the treatment of choice. There are other things to look at. They're much better than Tylenol. There are some studies that say, you know what, Tylenol's not bad. For certain people, it could be as good as anti-inflammatories. Advil's better than Motrin. I put that up there because folks don't know the difference. Are you taking ibuprofen? Nope, just Motrin. Same thing. No, I'm taking Advil. No, I'm taking Motrin. The patients are confused about what these medications are. They're all the same. And the truth is also, they are all pretty much the same. But the recent literature tells us to be safe, you know what, let's not just use them at random. Use the lowest dose that you can to help you. And they could be effective. Long-term use should be avoided. We have folks that would be on these for years. We're trying to get away from that with other options as we're talking about today. There's the bad guy, Celebrex, 2004. The whole issue about Celebrex and Vioxx came along. Vioxx taken off the market, and all of a sudden these drugs are killers, right? Arthritis drugs are killers. We who take care of arthritis went through a lot in the office. People wanted off these medications. They wanted nothing to do with it. There were a lot of concerns and confusion. Here's the final fallout on Celebrex. So the fallacies are, causes heart attacks in healthy people, and it's the super drug. It's much better than regular NSAIDs. Well, the facts are, Celebrex is still on the market. The FDA finally concluded that Celebrex and naproxen and ibuprofen all have this similar degree, albeit very low, of risk to your cardiovascular system if you take it for a while. We have never been able to quite accurately describe that, but all the other ones aren't off the market. Celebrex remains on the market. It is better for your stomach if you have ulcer problems, but it's not the super pill. It's not necessarily better than all the others. It's a little bit safer, but it is not terrible for you. Patients still recoil from a medication that could be very helpful, and we hate to see a patient lose an opportunity for something that could help them because of a misperception. The innocent opioid poppy. Opioid analgesics, narcotics, another bad word. As we said, Vicodin. Fallacies, I'll get addicted. Oh, I don't want to start on that stuff. Why not? Well, I'll get addicted. Well, what does that mean? I don't know. I just don't want that to happen. People just stay away from these medications. Or if you put grandma on narcotics, she's going to get woozy and break her hip. Or if you put grandpa on it, he's going to go crazy and drive his car through the mall. These are all fallacies, none of which are supported by medical literature. As a matter of fact, for people who can't have a joint replacement, who can't have surgery, who can't have some of these options and need pain medication, American Geriatric Society endorses the use of opioids. When used carefully and with good judgment, they can be very, very effective in people. And again, I hate to see people recoil from something that they can help people do what they need to do in their daily lives. But there are many, many misperceptions about opioid therapy. Corticosteroids. Corticosteroids, prednisone, steroids, they're all the same thing. That's another thing that folks get confused about. What is what and how does it come together? And we're talking about anti-inflammatory steroids, not this kind, not home run steroids, but anti-inflammatory steroids. So I mentioned that. Well, how about we do a shot in your knee? No, I don't want that. Steroids are, I heard, they're bad. Well, what'd you hear about them? I don't know. They're just bad. A lot of the stuff we understand about steroids are from old studies and misuse from when steroids came out years ago. It was a great drug, so we overused it and used it in too high a doses and problems developed. And some of that lingers. Or it destroys your joints. Or you can only have 3 shots in an entire lifetime. Not necessarily true. Steroids for the right thing and for the right time, when you have a sore, swollen knee, can be fantastic. The medical standard is 3 to 4 injections per year. Some studies show more than that can be safe, but steroids can also be very, very beneficial when used at the right time. Big word, viscosupplementation. Some of you probably have never heard of it. Also known as an oil change, also known as the lube job, or probably what you have heard of is the rooster comb shots. Oh yeah, my neighbor had those rooster comb shots. The protein to make this is derived from nature, it's derived from rooster combs. Part of the process of osteoarthritis is the fluid that normally lubricates and protects your joint goes bad. It gets thin and watery, and we have come up with an oil change, a replacement. And it's derived from nature, so it's very safe. And the fallacies are, well, it's the very, very last thing you do before knee replacement. Not true. Or the treatments really, really hurt. I heard about that, they hurt. Well, it ain't the arrow, it's the Indian, as the saying goes. It's the needle, and it shouldn't be that bad. Or it's not the same as corticosteroids. Doesn't have side effects. This is a wonderful treatment. Can be used any time in the treatment plan. Doesn't have to be just before knee replacement. Has no systemic side effects. The folks in your family that you're worried about, well, my mom or my sister has diabetes or is on blood thinners and has been told not to take A, B, and C. This treatment is available to all those folks. Has no drug-drug interactions. Does not react with anything. And with the newest product, can offer relief for up to 6 months with one injection. A lot of patients aren't even aware of this option. And again, maybe this is what belongs in your soup to make your soup absolutely the best. And finally, we had a good discussion about the malalignment that happens. This is the arthritic knee, the bow-legged knee that develops, and patients will come in and say, well, how can I help you? Because again, everyone wants their pain to be improved. But, well, I want my pain to be improved, but I also want to play golf again, or work out in the yard, or go for a walk, or walk on the treadmill. And I'd like my knee to be straight. Now, I'm a non-surgical specialist. Making the knee straight is pretty tricky unless we do something like this. We're talking a bit today about braces. Underused, underappreciated. They're the things that can straighten out the mechanics and allow people to go back to do what they want to do without drugs, without surgery. So the fallacies about bracing, well, canes, and also canes could be very helpful. Well, I don't want that stuff. They're for old people, or they don't work, or I've heard. Well, the new technology, the new way these things are being developed, very customized, very specific for the patient, they can be fantastic. So they're underused and underappreciated. And knee bracing, for example, can reduce pain, improve stability, and reduce the risk of falls, which is one of the #1 concerns of seniors. And again, also a concern probably somewhere in your family. Worried about falling down and breaking a hip, and knee bracing can help that. So I like to look at osteoarthritis. It used to be, well, there's nothing you could do about it. I just have arthritis. There's nothing you could do about it until you need knee surgery. Well, arthritis is changing from a disease of acceptance to one of opportunity, said by a not-so-famous physician as Dr. Stedman. It's just me. But thank you for your time this morning. I appreciate it. Thank you.